So let me introduce my colleague, Victor Stepenko, who's going to introduce our program and our speaker. Thank you.
Thank you very much, John. Hello, everyone. Very welcome to our webinar, to our international webinar. We're really happy to host all of you digitally. Just a short information, probably that would be interesting for you today. We're hosting people from 41 countries, from Latin America to Mongolia to Australia. So literally the whole world is now connected. Let me go to introduction. I would like to introduce you our speaker, Dr. Mariusz Pieczak from Poland, from Łódź City. Mariusz was graduated on the Faculty of Dentistry in Medical University of Łódź. He also completed his doctoral thesis in this university. He has over 13 years of experience in the field of conservative dentistry and endodontics. His professional interests also include aesthetic dentistry, prosthetics, and dental surgery. Mariusz is running his private office in Łódź, and his specialization is endodontic and conservative dentistry. He's a speaker. He's an international speaker since 2011. He's one of our core speakers in Central Europe. And during his free time, he is passionate about motorcycles and traveling to various unexplored places with good food and nice music. I've completely forgot to introduce myself. My name is Victor Stepenko. I'm senior sales manager working for VDW, and I'm responsible for business development in Central and Eastern Europe. Once again, thank you very much. We believe that this webinar will be interesting for you, and you will learn something new, information which will help you in the future in your everyday practice. Now, let's go directly. Mariusz.
Yes, I'm here. Thank you very much, John. Thank you very much, Victor, for introduction. Thank you very much. Thank you. Hello, everybody. Of course, we have a lot of participants from all around the world. I can see. So I hope we can start. So I hope it will be helpful and interesting for you my presentation. Thank you for your survey. It helps me to proper match the presentation to your expectation. I saw that you are interested in CBCT as much as in FRG. It's very good. And you are mostly intermediate and advanced in Endo. It's very good for me as well. Hope it will be favorable for you to my presentation. And in the end of the presentation, it will be a question and answer session. So I'm waiting for questions. And okay, we can start. When I was riding last time on motorcycle, I have great opportunity to admire potter workflow. It occurs to me that it's endless ways of curve in clay. Each potter has his own style, approach, and workflow to make a great unique curving. And then I realized that something is in Endo. Each endodontist has his own way to scout, to shape the canal, irrigate, and for sure to obturate the canals. In my opinion, endodontics is like an art. Our goals are the same, but we have a many different manners to achieve it. Doesn't matter if we are going to shape, irrigate, or obturate the canal. The most important thing is to make a plan dedicated to precise case. Before I will start, I'm always analyzing FRG, as I said before, CBCT scans, and I'm going to make a choice what kind of instrumentation I will need. During the checking of the CBCT, I'm searching if there are some alterations, ledges. I really focus on curvatures, which I will have to face with. Curvatures, I mean radius, degree of bend the canal, and connections between the canals. Can we skip, John, to the movie, please? Thank you. In endodontics, as I said before, we have to choose our way to shape, to scout the canal. Hand files, pre-flowering. We can choose any systems in the market to shape the final shape the canal, and of course we have to choose how we are going to irrigate, what kind of solutions we are going to use, what kind of obturation technique will we choose in the end of our endodontic treatment. Thank you, John. Bacteria that have penetrated deeper into the structure, lateral canals, dentinal tubules, and are obviously more difficult to reach directly to this by instrumentation. Nevertheless, adequate instrumentation does play a key role in facilitating the elimination of control of dentin infection. And technically, the goal of instrumentation or irrigation is to remove over necrotic and vital organic tissue, and give the canals and shape that allows easy debridement, predictable placement of local used medicaments, and permanent root filling in the high technical quality. As you can see, the patient came to my office because of the symptomatic upper molar. The vertical percussion was positive. So I made a small, I'm doing as small the determination point as is possible, or it is necessary in this case. So I'm really focused on this as smaller determination point as possible. So I made the determination point, and I was searching for one big oval canal. But as you can know, obviously you know the Vertucci classification of the root canal the classification, connections, etc. So it is not obvious that the second upper premolar has only one canal. In this case, it was one big canal, but with two apicals in the end. So it was very difficult to find another apical in the end of about more or less 3-4 meters from the end of the main canal. So I pre-curved, as you can see, I pre-curved the C pilot number 15. I'm always doing the same thing. Anyway, if it is a regular canal or is a curved canal, so it's a typical way for me to shape the canal, to sculpt the canal, and then I find the apical part of the second canal, the second canal, and I put the mechanical handpiece to put the hand files into this, and prepare to prepare the canal to put the mechanical instrumentation after it. Then, when I was ready to use the rotary systems, I choose in this case, I choose a reciprocal blue. It was number 25. And I do this the same as I done with the hand file. So I pre-curved the reciprocal blue because this file give me the opportunity to pre-curve it, and it's very easy and very smooth way to shape the curved canal as well. After it, I use the irrigation protocol, of course, sodium hypochlorite, 5.25%, and of course sonic activation, all the preparation of the shaping. And in this case, I choose the obturation technique. It was continuous wave technique, so I fit the main to the perker point on the all working length, and cut it on the 3 meters behind the apical part, and I put another one with the perker point, and then I filled all length of the main canal with extruder. And in the end, I put here the fiber post and on the second appointment, and I made a direct restoration in the end. The new generations of instruments undergoes complex heating, cooling, preparatory treatments to optimize the crystallographic phase and of the phase and transformation behavior of nitty alloy. And in moving it closer to the body temperature, it creates a shape memory alloy that it claims to increase the mechanical properties of the instrument. Blue alloy significantly increases the cycle fatigue resistance of reciprocal files compared with M-wire alloy. Temperature significantly affects the fatigue life of nitty files. Then the ambient temperature increases, the fatigue resistance of the files decreases. And further studies should be designed to determine how it will be possible to clinical apply these observations and find a clinical strategy that may improve the life and span of endodontic instruments, such as warming them up or cooling them down directly during the clinical practice. Always I'm choosing, well, maybe not choosing, but I'm using both techniques, FRG and CBCT, because I'm really interested what's going on. And it's the second case will show how important is to compare, how important is to combine both the techniques in one to make a good decision. I would like to focus this next case shows how to avoid failures once you efficiently plan your treatment based on the proper analysis and in-depth comparison on FRG and CBCT. And patient was referred to my office because of active fistula in region upper first molar. The percussion was positive as well, so I decided to make a CBCT scan as well. John, can we skip to the movie, please? Thank you. I decided to make a CBCT scan, and what occurs? I would like to focus your attention on buccal lamina. Buccal lamina, because due to the significant inflammation, as a result, the whole buccal root is out of the bone. As you can see, there's no bone surrounding the root from the buccal part, from the buccal side. Okay, John, can you skip to the presentation one more time, please? Okay. Can you skip to the movie, please, one more time? Okay, thank you. Okay. Here again, you can see on the CBC analysis, you can observe the major root deficiencies. Gangrena can be caused by many reasons. For example, irreversible pulpitis, or for example, overloaded occlusion. As you can see, the buccal side of the root was out of the bone, as I said before. There was no root surrounding the canal from the mesial, distal, and the buccal side, not at all. So we make a very difficult decision if we are going to extract this tooth or we are going to treat it. After conversation with the patient who has to say yes to, we can start treating, or we are going to he needs to make a decision what we are going to do, but we need to speak with our patients. So I'm spending a lot of time to speak with patients about this case, each case which I have to focus with. So we decided to treat it, and it goes without saying that the patient appeared in my clinical earlier, so the root deficiency could be much smaller, and the patient would suffer less, of course. And you can see that you can see two different ways, but compared in the one shot, and it means that I recommended going CBCT as a standard in my office. Can you skip to the movie, please, John? This on the right side, you have to recall the movie from the CT scan. It was recalled after 5 months, and as you can see, the canal was shaped, and it was a 2-session treatment. And I operated the canal with biomaterial, but as you can see, the healing, it was not maybe the full healing, but the lesion was smaller in the half. It was half of the previous CT scan. Okay, John, thank you. For me, maybe not only for me, maybe only for me, I don't know, but I believe that the broken file is always a challenge, and everything depends on placement of the separated file. The second factor, in my opinion, is how many tissue surrounding the file do we have. It's very important in terms of removing technique, file technique. The patient, this is the second, this is another case which I would like to share with you. The file was shallow, situated the canal, but the fragment separated into a file has more or less 5 millimeters, and the tulle file is a metal alloy, so it's very open. Instead of the piece of one piece, we have 2 pieces to remove. I'm sure if you do have the same experience, but in my practice, it's sometimes I have 2 or maybe even sometimes 3 pieces to remove. Then in the beginning it was only 1. I prepared the restoration, so it's quite easy to put the rubber dam on it, and we can feel safety, of course. And the proper restoration is the proper isolation. Then the broken file occurs in the buccal canal. So I was very happy in this case. It was so shallow, so it was not even very difficult to remove the broken file, to remove the lentil separated file. And I was lucky because I removed in only 1 piece. So it was very easy to make. I removed the old Gudaperca from the canal with blue wire reciprocal blue file. Then I was scouting with the hand files, and of course I was using longer irrigation protocol, where I'm using all the time sodium acetate and sodium hypochlorite, and in the end of before I obturate the canal, I'm using 97% of alcohol. Then I obturate the canal as always. I'm using main with a perca point for all length weld in this technique. So it's a continuous wave technique. I'm fitted the main with a perca point half meter before the full regular length, because the plugger is going to overheated with a perca point, and it's going to put directly into the apex. So I'm feeling more safety if I have a half meter before the all way to left, the main with the perca point. And as you can see, it was before the main problem in this case was to properly restore the coronal part of the tube. Then it's much more easier to remove the broken file, because we can see directly what we are going to do because of the rubber dam, and we can going to be safe. And as you can see, it is scouted and a full shaped, the full shape of the canals, and is going after the full obturation. After obturation, on the second appointment, I put fiber post in the 3 millimeters, more or less 3 meters below the bone level, and I put on the full ceramic crown on it on the third appointment. And it's a final situation. It was before broken file, not without any good treatment. Before it was a big problem with the coronal part of the tube, and you can see this, it was one session treatment, full leg left, 2 canals, and the third on the fourth appointment it is final situation. And only one, I would like to show you the main case when I put all the my skills into to focus with, because it was challenging case for me. I hope you would say the same thing, because as you can see, the same problem as before. We have before the restoration in the coronal part, we have some old cement put on the orifice, the canal, and the not big but not small as well lesion in the apical part. As I said before, the Vertucci classification sometimes it's going to fun to play with us, and it was the same thing in this case, because I'll show you later, but in the one of the canal it was broken file. When I was thinking about this case, I was supposed this is gonna be only one, or maybe because of this this shadow. I was thinking it's gonna be 2 canals, but life is going to be very playing with us, and I started with the good restoration, and then I can only put the rubber dam as always. I'm not doing endo without rubber dam, not at all. As you can see, we have an old with a perca, some resin inside, so I have to remove it. I used the ultrasonic unit to remove it. And in the root canal shaping from the aspect of Saxis endodontics treatment, it is very important to maintain the original form of the canal as far as possible, while the root canal is being gradual enlarged from the apical to the coronal region. And it was for me, it was very important because the article says that the reciproc phase group was found to remove statically significant more resin at all the measurement point when they compared with another files. So I used the 2 reciproc blue files, because I found the palatal canal and I was searching for the buccal one. In the beginning, I was searching the buccal canal, maybe more or less in this area. But as you can see on the second slide, the hand files showed that the buccal canal was much more closer to the palatal than I was thinking before. So I scout the buccal mesial canal, and I already shaped with the reciprocation movement the palatal side, the buccal canal. But I have another challenge. As I said before, it was a broken file. So I have make axis. I remove the old Gutta perca, and I have to focus with the broken file. Maybe it wasn't so deep. Maybe it wasn't so long to remove it. But believe me, it was very challenging. But I will show you why. This is another very interesting article, because it shows that allows the preparation of curved root canals with the reduced risk of heterogenic errors such as intracanal breakage and transformation. That's why I decided to use a blue alloy files. It's in the palatal and the buccal buccal mesial canal, I use the reciprocation movements, but in the another one, I will show what I use. As I said before, the palatal one, I shade with the reciprocation movements with Reciprocal Blue R25. Then I skipped to my protocol. It's always I'm going to shape the canal, to scout, to negotiate the canal with the hand files. It's always, and it will be always, I suppose, it will be always C pilot number 10. Sometimes I have to say sorry to number 8 or number 6 as well. And then we can choose, or we can go with protocol using air pilot, which is going to make for us the glide path. So it's going it's going to glide path for us and to prepare the canal for the final file to shape the canal. In this case, it's the reciprocal blue R25. Or we can skip the air pilot and go straight from the hand file number 10, go straight to the reciprocal blue R25. I'm always using an irrigation protocol between all the reciprocation movements session. I'm using always a sodium hypochlorite solution, and I'm always double activate. First of all, I'm going to preheat it to make a warmer sodium hypochlorite inside the canal using an endo track, and then the same solution in the canal I'm going to use to activate with a sonic system, like in this case I'm using always eddy system. Then I'm going to catch to make a overwanking left with the hand file. And then I'm going to prepare apical preparation. I'm going to make an apical preparation with the hand file using a balance force technique. And when I go to the all waking left, I'm going to skip to the reciprocation movements in reciprocal R25, because mostly I'm using R25. Sometimes I'm using R40, but I'm using it at 50, maybe one per week, per month, or twice per month, sorry. And I'm going to make 3 sessions with reciprocation movements, up and down, up and down. Always, as you can see, I'm always using irrigation, as I said before. And then I'm going to make a final irrigation protocol. As always, is always sodium hydrochloride activated, double activated, and in the end I'm going to use I'm always using the alcohol, and then I'm going to skip to the obturation protocol. When we have some problems, we can use another protocol, because if you are going, as I can see in the end, in the beginning of the presentation, you are intermediate advanced in the endodontics. So if you are if you are going to make some new technique, maybe it's news for you, and we are going to use a glide path and preparation without any hand files. As you can see, I don't use in this protocol. I'm not using not at all any hand files. I'm going to use reciprocation movements with reciprocal blue R25. How deep as it's possible, and then I'm going to use, of course, irrigation, and then I'm going to skip one more time for 3 sessions with the R25 to the deeper and deeper and deeper. And of course, I'm using always the irrigation protocol, but if you have some problem with this protocol, we can skip and we can combine the both protocols all together. So if the reciprocal is not going for the full ranking left, we have some problems because of the ledges, because we have some obliterations, because with some big curvature, and we are going to we are afraid to go soon with reciprocation movements file for all waking left without any hand files. We can skip to the hand file one more time to make a apical preparation with the hand file, of course, with with balance force technique, and we are going to reach the all working length. We can skip one more time to the reciprocation movements R25 for full working length, irrigation protocol, and we are ready to obturate the canal systems. But if the number 10 is not going for all working length because of the duration, is the main reason why we are going to skip to the number 6. We can have to say sorry with the number 6. C pilot number 6 is the best solution for the cases like this. Number 6, number 8 protocol, and we are going one more time for 6, 8, 10 down pack technique, and then we are going to use R25 irrigation protocol, and we are ready to obturate. Why? When we have to choose R25 reciprocal blue, when the number 10 C pilot, so it's a hand file, or at number 15 hand file, is going to, we have to make some work to reach the to the apical part. Then we are going to choose the R25. When the number 10 is going to very smooth, is going out of the apex very smooth, so it's not a good idea to choose number 25 because it will not do any works for us in the apical part. So then we have to skip to the number 14. If the number 15 number hand file or number 20 will doing some works in the apical part, then we are going to choose number 40 of reciprocal blue. And when we have to choose number 50, when the number 25 or number 30 will make any good works in the apical part, then we are going to choose number 50. Okay, so as I said before, I shaped the palatal canal with R25 reciprocal blue. Then I have to focus with the broken file inside the canal. It wasn't so easy because it was some ledge surrounding the broken file, so it was very difficult to remove this broken file from inside the canal. But it was dropped out in the end, and it looks like this. I was thinking that it was only 2 canals, but as you can see, it's 1, 2, and 3 canal inside the upper premolar. So it's very rare case. That's why I decided to show you this case, because I think it's very interesting. So it was elbow, and it was zipped canal transported as this file striters. So if you are going to not pre-curve the hand file, we are going straight, so we can do some via falsa. So I'm always, as I said before, I'm always pre-curve the shape canal in the file in the end in this area, and I'm going to make some bypass, or as you can see in this case, I removed the broken file. When the broken file was removed, I decided to scout the canal with hand files one more time. Anyway, that you have shaped the palatal and another buccal canal with rotary files. I decided anyway to use hand files one more time, and as you can see, is a it's a S curved canal. So it was very difficult for me to use another one reciprocal blue, sorry, R25, because of the typers. So in this case, I decided and I was thinking how to solve this problem. So I decided to use a rotary system because of the dentin quantity in upper premolar. When I used the 2 reciprocal blue with the bigger typer, I decided to use a basic, as I said before, sequence of rotary file. And difference lies in the fact that taper of the rotary file is smaller than the reciprocal blue, and that is obvious. The quantity of cut dentin is smaller, so it is basic sequence of rotary system, C pilot number 10, full rectangle length. Then I'm going to use a first file from the basic sequence of rotary system. It means it's a 1504. As you can see, I'm going to use in 3 sessions. Up and down, up and down, up and down. It's a rotary system. And then I'm going to use the irrigation protocol. As you can see, in the first access to the apical part, I'm not going to go up forwards to the apical part. I'm not taking care about the apical patency, but when I use the rotary system, the dentin debris are going to be applicated in the apical part. So then I'm always using I'm going to take an apical patency, and with the hand file is always a number 10 for me. So when I took care about the apical part, then I can skip to the second file in the rotary system. It means it's a 2005. So it's only one size in ISO classification in the apex area, but the taper is going on the 1% more than the first one. Then, of course, pre-session and the irrigation protocol. And in the end, you can choose between 2504 or 2506 file. In this case, and I said to you before, it was very. I was focused on the taper of the files, so that's why I decided to choose reciprocal blue R25 in the palatal. Reciprocal blue R25 in the buccal distal, but because of the dentin quantity surrounding the file, because the upper premolar is so it's not as big as the molar, so that's why I'm really focused about the dentin surrounding file. So I decided to choose a smaller one, 2504. In this case, rotate system. And as you can see, this is the ultimate situation, final situation. One more time, I restore the coronal part. I remove the old cement from the orifice of the canals. I found the 3 canals, not only 1, not only 2, but 3 canals in the upper premolar, and I took care about the healing after removing the broken file inside the buccal, the distal canal. As you can see, I said before, it was ledge surrounding nearby the broken file. To be honest with you, I am not sure if I made it or it was made before me. So anyway, I need to focus with the ledge as well. So that's why I decided to shape and to scale the canal with the hand file, and then pre-curve. As always, I'm going to pre-curve the rotary system if it's possible, and the rotate system gives me this opportunity. It's possible to pre-curve the apical part of the file. That's why it was very easy for me to scout the canal with hand files and use the pre-curved blue alloy rotate file to the apex. As you can see, one canal, second and further canal, all together they had the same apical part. So it was very easy to operate the canal, all the canals, because I used the palatal canal as the main canal. That's why I put the main good perca point in the palatal canal. Then I obturate the apical part, and then I use the square technique to obturate buccal mesial and buccal distal canal. And what does it mean final result? For me, final result, it means make a good choice, because to make a choice, what kind of technique to diagnose we have to choose. In my office, in my Endo life, I'm always compare and I was always combine all two techniques. It's always L4G, it's always CBCT scan. Another factor which is very important for final result is the instrumentation. As you can see in the this case, I choose two systems in one tube because I'm always going to think what is going to be better for the tube. If I'm going to make some typical protocol, or if you have some problem, you have to think directly during the treatment what kind of the instrumentation will be the best for this case. So I decided to use a reciprocal blue because of the taper in the palatal in the buccal mesial canal, and I chose in the end the rotate file to shape the S curves canal with ledge, and because of the denting quantity, it was very important to me to choose this kind of instrumentation, and your workflow, your experience, mostly is focused on your experience, how good your workflow will be in this case. So in the end, I would like to say that if you choose your way to prepare to shape the canal, to scout your canal, to even to irrigate or obturate your system, your canal system, you will choose your path during your endo life, and then you will win your endo. Thank you for your patience. Thank you for your being with me, and if you have some questions for me, you can directly send me a message for my email or my Facebook. It's open account, so I'm really open to be in touch. Thank you.
Thank you very much, Mariusz. There are some questions here. Are you ready to,
yes, please.
To answer? Okay.
I'm always ready.
Great. What is your irrigation protocol, Mariusz? Can you just drop
my irrigation protocol?
Yeah. Drop some key stuff about irrigation. Maybe what are the solutions? How you activate irrigants and so on.
Okay, normally in my typical protocol, I'm using only sodium hypochlorite. Since I'm going to negotiate, scout, or shape the canal, I'm only using sodium hypochlorite because I'm really afraid of the ledges or via falsa. So that's why I choose only a sodium hypochlorite. But the final protocol is combined sodium hypochlorite and sodium EDTA. Both solutions I'm always activate with the EDI system, so it's the sonic system. But sodium hypochlorite I'm going to preheat it with the Endo track before I will use the EDI system. And when I'm not using, if I'm going to use a 2-seal or AHA plus HE plus resin to sealer to obturate the canal, I'm using alcohol in the end. When I'm going to use the biomaterial to obturate the canal as a sealer, I'm not using alcohol in the end of the final protocol.
Okay. Another question. So finally, reciprocation or rotation? How to make a choice? Maybe you can give some suggestions to participants.
Yeah, it's very good question, but I strongly believe that it depends on the case which you have to focus with. As I said before, it depends, in my opinion, of the denting quantity, and mostly it depends on the curvature of the canal. Because if the canal will be really curved, it's a big curvature in some canal. I really advise to use a rotate system, but rotate system or rotation systems. But it's going to be, it should be a very flexible system. That's why, in my opinion, in my workflow of the Endo Light, I'm using a rotate because it's a blue wire, a blue alloy, which helps me to focus with the big curvature in the canal. When the canal is more or less is a straight canal, or between 45 till 65 degrees, I really advise to use reciprocation movements. It's in my practice the reciprocal blue because it's only one file technique. You don't have to make any protocol. You don't have to change any file. So in these cases, I will choose the reciprocation movements because it's much easier and much quick. It is more quick than the rotate system is.
Okay, another question. How many times can you use reciproc file? Do you have one per each patient?
It is very good question. The process it's a design like one single use technique, to be straight. But as a practice, as a practitioner, I will be straight with you, and I will tell you that one file of reciprocation movement, the reciprocal blue system, you can use even up to five canals. So if you have a patient with maybe, for example, 1 molar or 2 molars on the same appointment, you can use one file to 2 molars very easily.
Okay. Okay.
But
Thank
it
you very much.
depends on the curvature. Yeah.
Yeah. Sorry for interrupting you.
No worries. But it depends what the angle of the curvature it will be in this case. Sometimes if I have a big curvature in the canal, I'm using one single only one time. So it's very important and it's very depending on the curvature of the canal, in my opinion.
Mm-hmm. Thank you very much. Another question. Why do you not use alcohol in canal when using bioceramic?
Because the bioceramic needs some liquid inside the canal to set inside because it's a hydrophile material, so it needs some liquid inside the canal. So that's why I'm not using alcohol, because the alcohol makes a dry of the inside the canal, and the material will not proper set inside the canal after using the alcohol.
Do you always succeed to bypass the ledge? What are key factors?
It is very good question, but I'm not always succeed with the bypass the ledge. Sometimes I give up with the bypassing, and sometimes I'm using square technique to obturate the canal with some ledge. But it depends how deep the ledge is, where the ledge is. If I remove the broken file. But what are the key factors? In my opinion, the key factors to be succeeded in to bypass the ledge is to going from the inside of curvature, inside of the ledge. We can't go. We can use. I not advise you to use to sodium ADT8 to make to bypassing, because it's very easily to make via falsa in this cases. So I'm really advised to using all this sodium hypochlorite to scouting or negotiating even the the ledges, and then I suppose it will be more succeeded than you are. Maybe if you have some problem. But it's very important to make, if you have some broken file and you are going to bypass the broken file inside the canal, you have to go from the inside the curvature from the canal. You can't go to, from the outside side of the broken file. This is my key advice.
Okay, great. Which fiber post system do you use?
To be straight with you, I'm not a big fan of fiber posts, but I'm using many different systems. But if it's possible, I'm going to avoid the fiber post inside the canal, because it's not necessary to make it too stronger. The fiber pores is not going to make stronger of the it's not going to make it stronger of the tooth. Sorry. If it's possible, I'm making a direct restoration and put onlays or inlays. Mostly I'm doing onlays. After each endodontic treatment, I'm not using a fiber post. It's not my typical protocol, but I'm using onlays. If I'm going to treat or retreat some cases of the molar cases, I'm always advised to patients to make a overlay on inlay on this tooth. I'm not doing any MOD or big OD or MO restoration in these cases.
Okay, thank you very much. What indicators are key for endo to save the tooth, in your opinion, Mariusz?
What indications? It's very difficult. It's very very good question, because if my favorite idea is to follow the Pascal Manier idea. So if you have deeper the margin of the filling is closer than 3 millimeters to the level of the bone, I will not doing any restoration. So I'm going to only maybe extrude the tooth with the orthodontic way, or I'm going to make I'm going to cut the bone up to 4-5 millimeters below the restoration level, and then I really strongly believe that the tooth will be survived. That's why I said before, if we're going to treat, we are going to decide that we are going to treat this tooth, we have to be sure if we can put not leaking filling, because it will be not a good idea for longer recalls.
Clear, thank you. Which sealer do you use?
Mostly I'm using, as I said before, 2-seal or HA+, but in some cases I'm using BioMaterials. It's very easy. It's very boring, but I'm using only these two kinds of sealers.
Okay. Another question: is it possible to replace eddy with passive ultrasonic irrigation?
Yeah, it is possible, but I really I don't have any more time to show you the cases. But eddy, I really like eddy, because it helps me to remove free broken files from inside the canal. Of course, I'm going to combine. I always combine all the techniques which I know. It depends on the cases, but mostly I'm using, of course, positive ultrasonic irrigation is good idea to make irrigation to activate. But as I said before, I'm always preheating the sodium hypochlorite inside of the underchuck, and then the same solution in the canal I'm going to activate with eddy. So it's my main two main ways of activating the solution inside the canal.
All right. Thank you. Another question, how can we retreat cases obturated with BioCeramic Sealer?
It is very easy when you are going, when the doctor before you used gutta-percha points to set, to apply the bioceramic biomaterials inside the canal. When he didn't use a gutta-percha point to apply the bioceramic inside the canal, then you have a big problem because the bioceramic is like a stone. It's very difficult to remove it from the canal. So that's why I advise, if you are going to obturate the canal with the bioceramic sealer, I advise really to use a gutta-percha point for all length and length, but it should be set in the canal. So then you have very easily, you can negotiate the canal using only hand files for all length and length, the gutta-percha point, and then you can very easily remove the bioceramic from the root canal with the rotary or reciprocation movements.
Okay, great. Thank you very much. What do you use? I think that in this case, it's about materials. What do you use for build-up or cold
to build
up? If I got,
I suppose it is. Yeah, I think it is typical composite. Sorry, it was typical composite. It wasn't nothing special, to be honest. It was some kind of, I can't remember, charisma or something like this composite. So it wasn't something fancy.
Okay. Considering so-called squeeze technique, when do you indicate it?
If we have some problems, if we are going to, we have some problems with, as I said before, okay, let's see. For example, if you have some MB1 canal and MB2 canal, if you have some problem with negotiate the MB2 canal, but you are really sure that all the canals are connected in the end, they have some connection, so they have the same apex. I'm full shape the MB1 canal, and if I have some problem with the negotiate the MB2 canal, I'm going to use a square technique, because I really believe that I will use a big force to apply gutta-percha inside the MB2 canal and put some sealer behind it, below it. I really believe that the square technique is going to be works with it. Square technique, I'm really advised as well in the bypassing the broken files when you have some problems to reach the full vehicle length. If you have no lesion, you have some broken file, you can reach the full vehicle length, and you have no lesion surrounding the apical part of the root, you can try the square technique. I'm always putting a sealer below the gutta-percha point, and then I'm going to do bigger force to plug the gutta-percha to the canal.
Thank you. Overlay versus full crown after treatment. What is your suggestion or opinion on that?
If it's it is a molar, is a premolar on the canine on the incisor, I really advise you to put maybe some veneers, or in the premolars, I really advise you, because of the aesthetic problems, I really advise to put some full crown. When you have to focus with the molar, it is not aesthetic area. So patient is it means that you can have to take care about the the tissue of the tube. So that's why I'm going to use always overlays.
Okay, thank you. And probably the last question, do you use EDTA and how long time need in the root?
This is a very difficult question because EDTA, this solution is making in 4 minutes it's make this solution of the 30% of the dentine. So that's why I'm using always sodium hypochlorite, and only in the final protocol I'm activate EDTA and sodium hypochlorite maybe 5-10 seconds each. So I'm not using more than 10 seconds or maybe 15 seconds for each solution. So I don't care if it's going EDTA or sodium hypochlorite. But as I said before, I'm going to warm up with the sodium hypochlorite. But EDTA doesn't like the warming up, so you don't have to. You can't even preheat the EDTA inside the canal. I'm only using passive irrigation system or ultrasonic irrigation or eddy system.
Okay, thank you. Another question just arrived. Do you use special file when you have obliteration?
Yes, it's a special one. This is a special course. It's called C-Pilot. It's always C-Pilot. As I said before, it's always C-Pilot. If I can reach the working left with the C-Pilot number 10, I really said sorry with the number 8 or sometimes even number 6. And I'm going down pack techniques. I'm going to number 10, 8, 6, 10, 8, 6, 10, 8, 6. And normally after 3 sessions of this kind of down pack technique, I always reach I strongly believe that you will reach the full working length.
Okay.
But I will advise you to pre-curve all each file because of the ledges.
Mm-hmm. Thank you, Mariusz. Have you ever tried using our pilot for obliterations? Or it's always...
Yes, twice.
Mm-hmm.
Yes, it was twice and we succeeded. But it is not designed to do the things like this. But you are really experienced. If you are big experience in endodontic, you can try it, but you can't push it very strong inside the canal. You can try it. It's going to be catch the dentin inside the canal, but you don't push too much.
Mm-hmm. All right. All right. Thank you very much, Mariusz. So it seems we're done with questions. Dear participants, before we closed our session, could you please leave us some comments about the experience you got from this webinar? Maybe you'd like to improve something in the future, or just everything you want to share with us. We will highly appreciate your inputs and your comments on that. That's probably it, John.
Yeah, that's right. Thank you, of course, to our speaker. Thank you for everyone who attended today and sent in the questions. So yeah, thank you for everyone joining, and have a good rest of your day, evening, whatever time it might be for you. I'll leave the room open just for a little while, even though we're going to turn off the microphones and everything. But if you want to continue to send in comments, we do appreciate that. So other than that, there will be a recording link that's made available to all of you and those that missed that comes around by email within a few days. But yeah, thank you very much.
Thank you.
Thank you very much.